A happy and fresh morning to all of you. A very warm welcome to today's webinar on virtual workshop of scientific writing and review and clinical research being conducted by Indian School of Urology in collaboration with Indian Journal of Urology. To begin with, may I invite the President Urology Society of India, Dr. Sanjay Kulkarni, to give his introductory and prudential remarks. Over to you, sir.
Yeah, thank you, Dr. Chawla. Myself, Dr. Sanjay Kulkarni and Dr. Lakshman Prabhu, we are together at the UACON, Urology Society of Uttar Pradesh Conference. So we are in Ghaziabad. So today we have an interesting program charted by Professor Chawla and Dr. Sujata Patwardhan. It's about virtual workshop on clinical research, scientific writing and review, and we have one of the best speakers to talk about it. Lakshman?
Yeah. So I think with the permission of the ISU chair, hi, good morning. We are from Ghaziabad here, attending a wonderful meeting.
Good morning,
when it is good morning, ISU events, we can't simply miss because you craft such wonderful programs. Thank you very much on behalf of USI ISU chair and chairperson-elect. Let me only remind the old maxims: publish or perish, and reading maketh a man, writing maketh a perfect man. We have a wonderful panel of Abhishek Singh, Dr. Rajiv Kumar, Ravindra Prabhu, a good friend of mine, nephrologist from Manipal, and dear friend Rishi Nair. I am sure those who have logged in today live will have a wonderful feast and they will get excellent inputs on the topic chosen by the ISU. I wish this webinar all the success. We will be intermittently in and out because we have some commitments indoors. So you will kindly pardon us. But greetings from all of us. Have a great show. Thank you very much.
Thank you, sir. Thank you, President.
Thank you, sir.
Thank you, Honorary Secretary Dr. Lakshman Prabhu. We'll be seeing you in between, sir. Please join in between and join at the end if possible, sir.
Yes.
So we continue, so this has been an endeavor of Indian School of Urology to promote the culture of scientific research, the environment of quality scientific writing, and teaming up to do a collaborative work amongst the residents as well as the member of USI. So today's program has been scripted on these lines. And the first topic is for the resident, especially it's very confusing and occasionally frustrating for young residents to choose a study or a topic for their dissertation or for any clinical study. And it is often said that if you have to have a good idea, you must have many ideas. And Dr. Abhishek will be dealing with the solution to the problem of the residents in choosing the study of their choice. In the second talk, we have Dr. Ravindra Prabhu talking about the systemic review and meta-analysis, and it is said that copying extensively from one source is plagiarism, but copying extensively from several is research. So he'll be just telling out how the different studies, when put together, how you can make a nice systemic review with meta-analysis. Dr. Rajiv Kumar, in our third topic, brings the importance of insightful, constructive, and very sportive peer review, both to maintain the quality of the published article as well as to make us all effective reviewers. And in the last, the mantra of success, working together, finishing time, and publishing together, Dr. Rishi Nair will be giving the importance of collaborative work and doing clinical audit in such a country. So may I have inviting the first speaker, Dr. Abhishek Singh, for his talk on the study of choice for the residents. Dr. Abhishek.
Thank you very much, sir, for this kind invitation. I thank ISU USA for this wonderful opportunity. It is humbling for me to speak with Rajiv Kumar, sir, and Dr. Rishi Nair, sir, both of whom under whom I work in the IJU. With that thoughts, I start the proceedings. I would be speaking on choosing a thesis topic for clinical study or during the residency. I have nothing to disclose. And whenever the first thought of research comes as a new resident, this is what happens to you. Your mentor or your senior tells you that it is a high time that you choose a thesis topic, and you're just flabbergasted. You think, what is an appropriate thesis topic to choose from? Do I choose oncology, prostate health, stone, andrology, basic science, or bladder pathologies? And you are extremely confused so as to which topic is going to yield you result. At this point, you are thinking about two things. Are you going to get through with your thesis clearly, or are you going to make a difference? So when it comes to choosing a research topic, let us understand the why, who, what, where, when of choosing a thesis topic or a research topic. So why choose a topic? Just simply because it interests you. So this is the answer to the question that why I have chosen a topic or why I want to choose a topic. Is there a subset of issues in urology that you really like and you have an opinion on? So this is why you want to choose a topic out of this situation. Also ask who will be providing you information on this topic. Who is likely to publish this topic? What is the population? Who is going to be affected by this topic? Do you know of organization or institutions who are going to be affiliated who are affiliated with this particular region of work? What is that? What is it that you are looking for? What is the major question? Are you looking for an improvement of vision in a device or a technique that exists? Say, if you are looking for PCNL, are you looking for bleeding? So what are you looking for? You must ask yourself. Is there a debate going on about the topic that you're thinking? So is surgical management better than medical management for lower ureteric stone? Debate of such sorts, are they existing on the topic that you're thinking about? There is a possibility that there can be a range of viewpoints on the topic that you have considered. Say cancer prostate, thinking about surveillance, surgery, or radiation. Where is your thought process going to be relevant, or where is your research going to be relevant? At the local level, national level, or international level? Recently, we had an audit published by Dr. Rishi Nair sir, talking about a single dose prophylactic antibiotic policies in and around the country. Is it relevant in India? Absolutely, because the sterilization practices are quite heterogeneous. So though in the Western world, it may be a standard thing to do, but in India, it is still pretty relevant. What are the specific places that that topic you have chosen may have an impact? If you're talking about relation of the stone formation to groundwater composition, then you have to be working in a region of Gujarat or Rajasthan, where this situation is relevant. When is a question that you need to answer, that the topic that you are choosing, is it something which is extremely current, emergent, or it is a thing of the past? If you're thinking about pre-stenting in RIRS, probably it was done only in a few years back, and now it is something that you tell the patient that you may be potentially doing. Do you want to compare topics of today with the topics of yesteryears? So do you want to compare an open prostatectomy with a robotic radical prostatectomy? So these are the things that you must ask yourself before you proceed to do something or choose a topic. So simply to answer all this jargon, choose a topic that you are interested in. But the bigger question is that how do you know what you are interested in? So first answer what you are interested in by checking out these points. Does the topic that we are talking about makes you lose sense of time? Do you like to read about the topic in question? Does it really rekindle a childhood passion in you? Are you enthusiastic about anything that has to do with this particular subject? And are the leaders in this subject your heroes? So if you're talking about stone, do you really want to scrub up in every PCNL case? Every new article that you come across on social media on stone, do you really want to read it? and do the Traxers and the Mahesh Desai's make you think of your childhood heroes. When you nearly sorted with what you want to do, narrow down to something which is manageable. So thinking only about the stone disease is not good enough. You really need to broaden get this broad topic to the narrow lanes of what is the area of need. If you are thinking about PCNL, are you thinking that bleeding is a concern in PCNL? So put this question to yourself again. Do a lot of background reading. It will help you limit the scope of what you are thinking about. Narrowing the scope can be done by a theoretical approach, like you look at the stone disease, think of surgical techniques, and then get to a sub aspect. Say you are thinking about stone disease, now come only to the area of fragmentation techniques and what is new there. Are you talking about new lasers? Also consider the timeline. If you're talking about something which is new and you're doing a retrospective analysis, you can't be looking beyond a timeline. Say if you're talking about TFL, doing anything beyond 2016 as a literature search will not have any relevance. Look at the population that you are going to deal with. Also look at the geographical location. Are you working in an area where you would be able to get adequate patient population to do your research? So if you are working in the southern part of India, say where the stone population is relatively less, or in your hospital the footfall of stone patients is relatively less, and you want to do a stone thesis, it may potentially be difficult. Sometimes you start with a really narrow topic, and this happens because you have chosen a fancy topic rather than really doing a good literature search. If your topic is too specific, like when TFL came, there was a lot of hue and cry that TFL causes ureteric strictures, and the TFL is present in your hospital for about 6 months, and you want to study stricture formation with TFL. Probably it is not a practical idea. If your topic is too new, like consider using lasers for partial nephrectomy, then again you need to go back to the literature, see what has been done and how practical it is to do this particular research. Your initial search may be limited and misleading. This may happen due to the really fancy comparison that you read sometimes on social media. So go back to the drawing board, go back to your literature search, and then broaden the horizon, and then again start to narrow it down. Ask yourself, what is known about the subject? If you are talking about, say, flexible ureteroscopy, so you know it is a minimally invasive tool. What is the knowledge gap? The knowledge gap is, can it deal with stones which are larger in size, say 1.5 centimeters? Because it is known that RIRS can manage stones up to the size of 1.5 centimeters. So what can you do about this knowledge gap? Can you do something so that RIRS can help manage larger stones? So how do you intend to fill this knowledge gap? Probably by using better energy sources, using something like suction, which will help you manage the larger stones. So when you put these questions to yourself, you will get an answer, and at the same time, your study will start shaping up. Making of a good research has 3 pillars: disciplined imagination, constructive criticism, and tempered aggression. As philosophical as it may sound, I go to an international meeting where I hear something about ARV7 splice mutation affecting castrate-resistant cancer prostate and the choice of drugs thereby. I come back and decide to do this research. I do not have any know-how of molecular science. I do not have a background support of a molecular lab. How am I going to do this? This is not practical. I have to discipline my imagination to a science which is possible in my milieu. I have to accept constructive criticism. When I draw the basic guidelines of creating a research, I go to first my peers and ask them, do you think it is a relevant question? Thereafter, I go to my mentors and ask the same question. Being aggressive definitely is good, but being over aggressive may only be harmful. I do realize that the thoughts of Dr. Ralph Kleeman, who says that your ask a clear question. Is shock pulse better energy than pneumatic lithoclast in PCNL? Or rather than asking analysis of shock pulse as an energy source, a clear question leads to an optimal result. Uh, is shock pulse better than pneumatic lithoclast? I designed either a prospective RCT, a retrospective comparative study, or a prospective comparative study. The possible outcomes are one is better than the other, or both are equal. This helps me get the inclusions of a straightforward case of PCNL and exclude all the situations where PCNL may be challenging and unsafe. And the conclusion is the answer to the question that I asked. My flow of thoughts should be initial question, followed by a peer review, followed by a mentor review, analysis of the initial question, deciding whether I want to do an observational or an analytical examination, and analyze the exposure and the outcomes. Points to remember are the hypothesis should be straight and clear. One exposure, one outcome. It should be specific without any ambiguity. Hypothesis should be elaborated at the outset. It can be expressed as a null or an alternative hypothesis. The suggested framework we all know is the PCOT, Population Intervention Comparator Outcome and Time Frame. For analytical studies and for observational studies, it should be population, exposure, and outcome. Define the population of the question that you have chosen, the size, eligibility definitions of the target population, decide the intervention, compare it with the current standard of care, analyze the potential harms and methods of recording the side effects of intervention. When it comes to a comparator, the requirement of a comparison group may be there. You may consider placebo or a sham intervention. At the outset, avoid multiple comparisons or comparators. Define the primary and the secondary objectives at the outset. Your study could have an exploratory or a confirmatory endpoint. The methodology should be defined at the outset. Consider the time frame. You start anything, put a time frame. What will be the recruitment date? Till what time are you going to recruit? What is the data recording date, analysis date? These arbitrary timelines will help you go through the entire process smoothly. Use the finer criteria to find if your study is feasible, ethical, and logical. This finer criteria will help you modify your initial thoughts. Look at the feasibility. If you're looking to compare lab versus robotic pyeloplasty and in your semi-private hospital where you work, this is going to be a very costly affair. So look into the feasibility of what you're doing. What are the interests? What is the potential readership? Are the other stakeholders also interested in what you are doing? What is the potential of citations? Is this study likely to get utilized for the reviews in the near future? Is your topic a novelty? This is desirable but may not be mandatory. If you are looking at medical expulsive therapy for lower ureteric stones, it still is a relevant thing, but it may not be novel. Ethics are the Achilles heel of whatever you do. They provide legitimacy and reliability to whatever you are doing. Is your question relevant in the current practice? Like consider a situation of use of suction in PCNL and then modify the study question. So sharing this example of comparative study of thulium fiber laser with holmium laser in a randomized controlled trial in a single center. So what we knew was holmium laser and thulium laser can both be used for RIRS. There were some in vitro studies which suggested that thulium fiber laser is faster, but the gap in knowledge was that there is no comparative study in vivo. So we decided to do a comparative study in a randomized fashion, comparing the thulium fiber laser and the holmium laser. The primary objective was a stone fragmentation rate, because we wanted to prove that whether thulium laser is faster than the holmium laser. Straightforward cases of 1 to 2 centimeters in a healthy population were chosen. A time frame of 1 year was defined, and patients who were not fit for RIRS or conventional RIRS were excluded. Material and methods were defined, that you would use the same scope, the said laser with the same access sheet, and all will be stented and analyzed at 1 month for stone-free rate, with ultrasound and X-ray. The stone laser fragmentation rate or the stone fragmentation rate was predefined as stone volume in millimeter cube upon active laser time. So this is how you define a question and set up the whole thing. With that, I come to my take-home message. Friends, well begin is half done. Ask yourself what are your areas of interest. Narrow down to a subject that is potentially an area of need. Understand the knowledge gap by doing a good literature search. Background reading can help you understand the intervention that can change things for good. Subject initial topic to peer and mentor review. Use the PICOT and PEO framework to set up the study. The finer criteria will help you refine your topic. Thank you for a patient listening, and happy research to all of you.
Thank you, Abhishek, for an excellent presentation. I think this would have cleared the doubts of many and probably answered many queries of the residents and the members who are in the stage of, say, of the ideation or conceptualization of any clinical study. Dr. Abhishek is chairman-elect of YUU, a section of Youth of Urology Society of India, is himself an excellent clinical researcher in many published articles in the Q1 and Q2 journals through his time. Thank you, Abhishek, for an excellent presentation. So we move on to the next presentation, that is on systemic abuse and analysis. And the speaker is Dr. Ravindra Prabhu. He is professor of nephrology at KMC Manipal, and he heads the Cochrane affiliate unit at Manipal Academy of Higher Education. He is a recipient of Kenneth Warner Award from Cochrane for his study published in Cochrane Review Group on hepatitis C in dialysis patient. May I invite Dr. Ravindra Prabhu to start his presentation. Over to you, sir.
Good morning. At the outset, I would like to thank Professor Arun Chawla and Professor Lakshman Prabhu for this opportunity. I feel truly privileged and humbled to be included in this panel, which includes some of the best teachers of urology. And I will be discussing the systematic reviews and meta-analysis. And the key word here will be systematic. It is not just any narrative review or a literature review. I'm going to discuss the basics of how literature can be included in a systematic way to produce evidence which we could use for managing our unfortunate patients, and also it would help in the publication of high quality publications. Basically, what a systematic review does is to answer a clearly specified research question, and there are methods of formulating this research question, which I will be discussing in my later slides. And this research question should be a focused one. And once you get the question, we identify the relevant studies to answer the question using pre-specified eligibility criteria. We assess the quality of the studies and then use perfect methodology to summarize the evidence. The whole idea being to minimize the bias in the process. So what you're doing is to include or exclude studies which will answer your research question. And therefore, many studies which may have small sample sizes, when they are included together, will increase the strength of the evidence. And there is a clear need in the present situation where we are faced with a deluge of literature, many of which may not be really good. And a healthcare worker who is faced with a patient whom he needs to manage, or who needs to train a student on the correct way of doing things, he needs evidence for that. And this is one of the best ways to generate high quality, relevant, and up-to-date information on the process. Again, if you also want to do primary research, you would also want to know what is the previously done studies on that, and a systematic review would really help out in that, in doing that. There are number of types of systematic reviews, but basically, as a clinician looking into the literature, we are interested in the interventions only. And that intervention could be in the form of any medications or vaccines, or in the surgical field, it could be devices, or in the community field, it could be prevention, or for a person in the health sector to determine the policy. Of course, lately we have the reviews of the diagnostic tests, prognostic reviews, reviews which evaluate the synthesis of evidence, reviews which assess the methodology of how the studies are done. And of course, if it's a broad question where with multiple subsets, then we could have overview of reviews. And many of the times nowadays, with the availability of internet, you could do the review across the globe, and this could be done rapidly, and also they could be updated on a real-time basis. That means the review is always live and is continuously getting updated. Now, as I told earlier, why do we need to do the review? We need to have, as clinicians and as experts in the field, we need to be up to date, and we need to have complete understanding of the relevant research. And when we go to our wards and treat the patients, we need the evidence. That is the responsibility which we have towards our patients and to our students, that we use the evidence-based medicine, and the systematic review is going to give you that. And then whenever we make a decision towards a management, the decision should be objective, in the sense it should be balanced in terms of its benefits and harms. And so a systematic review will reduce that bias to the extent that it gives you the balance, and that makes your decisions impartial. And of course, it helps you to choose appropriate interventions. As the previous speaker told, for example, for the stones, you have multiple interventions. And if you take the industry, each of them would tell you that their intervention is the best. But you really need to go through the evidence, and these reviews will help you do that. And again, if you are planning a primary research, you don't want to repeat the same thing again, because time and resources go into that. And these reviews will help you to avoid duplication, identify research gaps, and also it tells you the limitations of studies which are already done, which you could improve upon, and also identify priorities for future research. Now, if you consider the hierarchy of evidence, what you would see is that at the bottom comes the expert opinion, which is very freely given, followed by case series, case reports, and then, as you can see, the systematic review comes above the randomized control trials. So we consider the randomized control trial studies as the highest form of evidence. And when you take multiple RCTs answering a particular question, you conduct a systematic review, and that will give the best evidence for a particular intervention or for a particular diagnostic test. So the steps for doing a systematic review process would start with framing a research question, and the research question should be relevant to our subject, and it should be relevant to our patients, and it should be focused. So if you are going to take a broad research question, then it becomes a scoping review, where you have to answer multiple small questions. Whereas in a systematic review, you would focus on a particular explicit research question, and then identify the relevant studies which will answer that question. Of course, even if it's mentioned it's a randomized control study, we still need to assess the quality of the studies to see whether they're truly randomized and truly controlled. And then you summarize and synthesize the evidence. The synthesis could be a qualitative synthesis or a quantitative or statistical synthesis, which you would call as a meta-analysis. And then as a clinician, you would then interpret that evidence and look into it, whether it can be applied to the patient who is in front of you. So as I mentioned, the research question should be an explicit and structured. And by structure, I mean it should follow the guideline of a PICOT structure, which means it should tell us the population which you are addressing, the interventions which are being studied, the control, whether it's a placebo or a standard of care, and the outcomes. Again, the outcomes should be very relevant to the patient population and it should be framed in such a way that it balances both the benefits and the adverse effects of the interventions and the time frame at which you would look into it. So in a systematic review, the study, the population is there for each study, and the unit of study will be the individual trials which are done and not the individual patient. So to give a brief example, one question could be in a community receiving municipal water, whether fluoridation prevents dental caries. So this could be a kind of research question, or benefits and harms of adding fluorine to water in children. So this could be the topic of a study. Then having thought of the research question, it is very important that we register it so that it is open to public and peer review. And some of the platforms like the Prospero allow you to register your reviews. And basically, this allows the reviewer to avoid any duplication. So we know that if somebody is already doing this review, we can avoid duplication of that. Again, it allows you to check for the skills and experience of the proposed team who's going to do the review. Review can never be done as a single person. You need a multi-author team with different expertise to do that. And it also may allow you to get appropriate support so that if it is important to the policy makers or it is important to certain organizations, you may get the support to do that review, and also helps you to check the suitability and how important the topic is. So having registered the review, we have to have a pre-published protocol. And this is one of the best ways to avoid any bias. So before you even start looking for the studies, we need to put down a protocol on how the review is going to be done. So the methodology of how you are going to do the review, and the protocol should be published without prior knowledge of included studies. So once you start looking at the studies and you start looking at the outcomes in the studies, one may get biased into including different outcomes which are favorable if you are biased towards the intervention. So ideally without prior knowledge of the included studies, you may have knowledge of the intervention, but you should not be actually looking into the studies at the time of doing the protocol. And then this in organizations like the Cochrane, which is a major organization which performs the systematic reviews, the protocol itself becomes a publication in the Cochrane database, and it gets peer reviewed before the review is started. And once the review is done, we should not deviate from the protocol, and any deviation from the protocol should be explicitly mentioned in the review itself, and why you have deviated also needs to be mentioned to keep it very transparent. And then again, the protocol will mention how one would plan to search and identify all the eligible studies which you are going to be included in the review. The methods of how you are going to search will be predefined, and the criteria for assessing any bias in the studies which you are going to include will be mentioned. And finally, how you plan to do the synthesis of results. So again, as I mentioned, it could be a qualitative synthesis, or if there are two or more studies which are answering the same question, we can synthesize the results, add them together in a methodological way through a meta-analysis. Now, what could be the criteria for including the studies? Basically, it depends upon the research question. That is, you have a pre-specified population, intervention, the control, and the outcomes. And any study which would look into these 4 criteria would be included. Then you need to pre-specify what type of study you would include. So basically, if you want a high quality systematic review, you could limit yourself to only randomized or randomized control trials. And for example, if you do a Cochrane organization review under the Cochrane organization, they would ask you to limit your review to studies like which include only RCTs. And then the decision on how you are going to synthesize, because each study may not measure the outcomes in a similar way. You need to have a methodology of how you are going to synthesize that. And so you have a review PICO for eligibility of study and a PICO for each synthesis and for the included studies also. Then having defined the protocol and the eligibility of the studies, then we need to extract the data. Once you get the studies, we need to extract the data, and based on the criteria which we have mentioned in the protocol. So for extracting the data, we need a predefinition of the condition which we are studying. That is, the question is addressing. Then the participants, the demographic characteristics of the participants or the population which is being addressed. What is the setting, because the outcomes will differ according to the setting, whether it's a community setting or it's a hospital setting or a nursing home, like that. The outcomes may differ, and that needs to be transparently mentioned. And which are the people whom you are going to exclude from the review. So whether it is going to include children, whether it's going to limit itself to a particular age group, which your question addresses. And then there may be studies which may overlap. So once you define the population, some studies may have the population which is being addressed by the question, and apart from that, they may also include some extra patients. For example, if the review is addressing only adults, and there may be some studies which include both children and adults, then how we are going to handle the studies which have only the subset of relevant participants, and there are methodologies for addressing that, which we need to mention in the protocol. Then coming to the interventions which are going to be taken up, basically it will be 2 groups: the intervention of interest versus the control or the standard of care. And again, the different studies may have variations in the dosage, the frequency with which the intervention is being given, how the intervention is being delivered. So each center may have their own protocol, and these kind of variations in different studies need to be addressed, which means that the analysis is not simply a summing up of the different numbers of patients in the different studies. We need to actually address these issues and include all the variations. We cannot avoid the variations, but we need to address it in such a way that the bias in the final result is minimized to the extent possible. And each of these issues should be clearly defined before we even start the review. And then we have the comparison, whether we are going to take up intervention versus placebo. Nowadays, it's very rare to get placebo controlled trials, because it may not be ethical to actually avoid standard of care, at least in the treatment. So basically, we are defining it as intervention with the control plus a standard of care, and then we may be comparing 2 different interventions. Then coming to the outcomes which we would like to study, the outcome should be relevant to not only the clinician, but also to the patients who are going to receive these managements, and also to the policymakers. So it should help out a patient to decide also to which intervention he would be consenting for, and also for for the clinician to make a decision on whether or not he can use the intervention in question. and the outcomes which are unimportant should be excluded from the review. And basically, if I take a Cochrane review, it would allow up to 7 critical and important outcomes. And basically, we should spread out the outcomes in such a way that it will cover both the benefits of the intervention and the actual adverse effects. The adverse effects we assess by means of treatment discontinuation, or means how many people have discontinued the treatment, and what are the specific adverse effects which are there. Then, having defined all this, we need to search, we need a proper search strategy. And here, part of the team should be a librarian or an information specialist. So basically, to avoid any kind of bias, we need to include all the studies within the time frame which have been done addressing the research question. Again, one of the bias could be that a study is done, but the outcome was not favorable, so it may not get published. So it may be available as a thesis, or for example, a PhD thesis, which not getting published because the outcome was negative. And so you may collect a number of studies which give only positive outcomes, but in the real world, when you use the intervention, the outcomes may not be positive because the literature on the negative outcomes has not been published. So we need a complete and thorough kind of search strategy, which would include not only journal articles. We have to go through the number of databases, clinical study reports. Very important to go through unpublished data. So some of the data could be just presented in conferences. It could be just available in trial registries, regulatory agencies, gray literature, for example, on certain websites of the organizations which are there for certain diseases, or as conference abstracts, dissertations, etc. So this kind of thorough search strategy is required so that you get all the studies which have been done within a particular time frame. So after that, one would actually have to merge the reports, because when we do a quantitative synthesis, if a study has been split into two and duplicated in different literature, we cannot just add it up because it would double the effect. So we need to identify duplicates and remove them. We should identify whether the study truly addresses the question and it is truly randomized. And this we could do by just examining the titles and abstracts. And if some doubt is there, we need to retrieve and examine the complete article before we take a call on whether to include the study or to exclude it. And sometimes some of the data on the outcomes may not be available, or the outcomes which we consider as relevant may not have been presented by the investigator. So you may have to email the investigators and get out the data. And so many of them would be really helpful in giving the raw data to the reviewer so that it can be analyzed in the way the outcomes which are required. And then we make a final decision on the inclusion. So there's a guidance from the Prisma flow diagram on this issue, where we identify a number of studies with the searching of databases and other sources, remove the duplicates, screen them for relevance, and exclude the irrelevant ones. Irrelevant means those which are not relevant for our research question. And then may sometimes we have to take out the full text articles, and then some would be excluded. And then we do a qualitative synthesis. And if we have 2 or more articles, then we include it for a quantitative synthesis, which is called as the meta-analysis. The data extraction itself starts with the date of the study, identification. As I told earlier, eligibility criteria, the methods, the study methods, how it is designed, and different types of design are there. Then the this description of the participants, and that the PICO format. And then the effect measures, that is the effect of the intervention has to be measured. And basically the measurement differs if the outcome is a binary outcome, that is can be answered with a simple yes or no. For example, death or event happening or not happening. It could be continuous. For example, if you're measuring the age weight, blood pressure. It could be measured as a continuous, or it could be in a ascending or descending order. That's an ordinal one, or the events being counted at the rate at which the events occurring being counted, and a survival analysis, that is the time to event analysis. So these are the different effect measures, and these are the different ways the effects come out, and they can be measured depending on if it is dichotomous, that is a binary one, then you could measure it in the form of a ratio measure, which would then convert to a log scale. Or if it is a continuous effect, then we take the mean difference or the standardized mean difference. And a very important thing about the review, as I mentioned earlier, is the risk of bias, which is a systematic error or a deviation from the truth, which means that the intervention, if you want to hit the bullseye, but it is systematically hitting the side of the board. And in a study, we don't have the board in front of us, so we don't know whether it is deviating from the truth systematically. So in this situation, there are methodologies which you could use to see what is the bias. So in a review, we cannot avoid the bias. We need to identify it and report it. So the person who's reading the review will know how much he can trust the evidence which is there in front of him. Basically, what the bias does is it can underestimate or sometimes overestimate the effect. And the bias could be in the way the subjects have been randomized. So it may not be a true randomization in the generation of the sequence. The methodology in which the blinding has been done, there could be deviations from the intended interventions. There may be selective reporting of only positive outcomes, and there may be deviations from how the outcomes has been measured, or there may be selective reporting which is done. And so based on this, the reviewer has to give a judgment for each study, whether the bias is low risk, there are some concerns, or there is a high risk of bias. And again, the conflict of interest also comes in. For example, if it is an intervention which is funded by industry, we would take that with a little bit higher risk as compared to completely government funded or an organization funded kind of research. And then we come down to the synthesis of the thing, that is the bring together the data from a set of included studies. Again, I want to say here that it is not just a summing up of different numbers. It is based on a study characteristics and a statistical synthesis, a tabulation of the study characteristics and the extracted data from that. And then we come to the meta-analysis. So whenever we use a software, like for example, the Revman software comes from the Cochrane, there are other open softwares available to do the review, which makes it very easy. There is a temptation to start with the meta-analysis, because as you enter the numbers, you would get what is seen on the right side, a number of studies coming up and a beautiful diamond which comes down, and it's very exciting for a reviewer to see that forest plot coming up with a diamond, but follow the steps which I mentioned earlier and then come down to the meta-analysis. What is a meta-analysis? It's a statistical combination of results. And because you're combining multiple studies, your sample size increases. So there will be an improvement in the precision. And we need to choose critical outcomes, or if I choose the suitable effect measures to get this down. Basically, the common method used is, as per the sample size, you have different weightages given to the different studies. A weighted average is there for each study, as you can see in the right side. And the final combined estimate comes in the form of a diamond, which is there below, which will tell you whether the overall analysis favors the treatment or it favors the control, or it is sitting on the middle. So sometimes if one may have a huge study and multiple small studies, or studies which are high risk of bias combined with low risk of bias. So in that case, we may have to exclude one or two studies and again do the analysis. And those kind of analysis is called as the sensitivity analysis. Again, when we are doing the review, we have to take into account the heterogeneity. That is, there are definitely studies done in different centers will have variation in terms of the population, diversity of the population, the way the interventions are given, and also the outcomes which are mentioned in the studies. So same question may be answered in different ways. And this kind of variation is called as a heterogeneity. We cannot avoid the heterogeneity, but we need to address it in a transparent way by mentioning it in the review, whether the heterogeneity comes at the level of population, at the intervention, in the control outcomes, the timing, that is the duration. Some studies may be short duration, some may be longer duration, and the settings in which it has been done. So these should be transparently mentioned in the review. And again, there are guidelines for how to report the review. What are the expectations in the methodology of doing the review, and the preferred reporting outcomes for systematic reviews and meta-analysis, which I mentioned as the PRISMA reporting. And having done the analysis, as a clinician, we need to interpret that. Simple interpretation would be the evidence which we have generated, whether it is answering my question or not, or I need further study on that. And then whether it can be applied to my patient, and with what degree of confidence I can use that intervention, and what is the implications for my practice, and what are the gaps for future to be addressed in the future research. So to conclude here, the review would start with getting a question to see if we are duplicating already a review which has been done or being done. We define the eligibility criteria for the study, design a search strategy, take out the references, and then take out the full text of the included studies, collect the data, critically appraise the data, analyze and interpret, that is, do a qualitative and a quantitative synthesis, then do the interpretation and write the report. So this is the circle of a review circle. And basically, again, I want to emphasize here that the research question and the protocol should clearly state what objectives you have. The methodology should be explicit and reproducible, which means that if somebody else does the same review, he should get the same conclusion anywhere in the world. And then attempt to identify all the studies. This is very important so that you have studies which report even negative and the positive outcomes. Assess the validity of the findings of the included studies and synthesize the studies finding in a systematic way. And if one is able to do this, again, we would be sitting at the highest point of the evidence pyramid, which will be of great help to not only our patients but also to be able to do some high quality publications also, and also disseminate an evidence base to our colleagues. Thank you very much for a patient listening.
Thank you, Dr. Ravindra Prabhu. Very tough subject. You have made the understanding quite simple. Thank you for a very lucid and erudite presentation. May I request Dr. Sujata to take over for the next presentation?
Yes, sir. Yes, sir. Can you hear me?
Yes,
yeah. Yeah. So I would like to invite Dr. Rajiv Kumar from AIMS Delhi. He is the professor and he is the editor of Indian Journal of Urology. And we would like to hear him on the critical review of journal article. Like definitely all of us are eager to know why and how an article is reviewed, and what are the final judgments and what does it depend on, and so many things to reviewing an article. So we look forward to your talk, Dr. Rajiv Kumar.
Can you hear me now?
Yes,
yes,
a
yes.
little faintly.
Okay.
Yeah.
Okay. Thank you, Dr. Sujata, Dr. Chawla, and everybody at the Indian School of Urology. And thank everyone for signing in on another Sunday morning. At some point of time, we'll have to start using our Sundays for ourselves rather than using it for everything else. But for now, let's carry on with what we are doing here. And I'm going to talk to you a little bit about critical appraisal. Let me begin by a clear disclosure. I edit a journal and I depend very heavily on both authors and on reviews. So when you review for me or when you write an article for a journal, you make our lives easier. Therefore, there is a tremendous conflict of interest, and that's a disclosure we have to make about making this presentation. If you're able to get across to you, you make our lives so much easier, both as authors and as reviewers. Over the next few, maybe about 20 minutes, I'm going to talk to you about what is critical appraisal and why do you need to know critical appraisal. How do you make a good paper? And remember, critical appraisal, that means reviewing for a journal, is no different from writing for a journal. To a large extent, it is the same thing. If you know how to write well, you will also know how to read well and therefore how to review well. Therefore, what I'm going to talk to you about today is the same as what I would talk to you in a lecture about how to write an article. To a large extent, it is similar. The only difference is that I will also give you a few tips on how to write your report when you submit the final report. But otherwise, it is very similar to what you would do for writing an article. And therefore, let's begin by understanding what do we mean when we talk about this big word critical appraisal. And let me give you a very simple example. Let's say you want to buy a car. You have a budget of about 10 lakh rupees, and there are a large number of cars that are available in the market for about 10 lakh rupees. Standard question that every Indian asks is, kitna deti hai? That's a standard question. You don't move forward beyond that. So let's work on that question. What is the fuel economy of this car? How many miles will I get to a liter of petrol? So let's assume one car is being sold to say give 20 kilometers to a liter of petrol, and the other car is being sold to say give about 15 kilometers to a liter of petrol. What are you going to do? Which car will you buy? If both cars are otherwise very similar, an obvious answer would be I'll buy the 20 kilometers per liter car. It gives you better fuel economy. But that's a very naive answer to give. A person who does a critical appraisal would say, all right, let me first understand how did you calculate your fuel economy? The guy who got 20 kilometers to a liter says, I ran the car with one person of 60 kg sitting in it, driving at a constant speed of 60 kilometers per hour on a runway with no air conditioning and the windows pulled down. So if I did that, I got 20 kilometers per liter. The other guy says, I got 15 kilometers per liter, but I had two people sitting in my car. It was being driven in Delhi on a regular Delhi road in the middle of summer with the air conditioning turned on. Now, which car will you buy? If you know what Delhi roads are all about, you'll say, I'll buy the 15 kilometers per liter rather than the 20, because that's a more realistic assessment of how my life is going to be. So that is a mileage which is more relevant to me. And that is what critical appraisal is all about. You don't just look at the fact as it is given to you, but you try and assess how that fact impacts the reality of the circumstance. So why do we need to apply critical appraisal when we talk about writing? There are very simple reasons. There are so many articles that are written every day that sometimes you wonder, is there really so much science happening? Is there really so much new that's happening that so many articles can be written? And the bottom line is there isn't. So a lot of what is written may often be unscientific, may not be valid, but if it gets published in a journal, it will influence practice. You will see an article which says X device is new and it's good. And obviously you get positively influenced and you decide, I may want to use this device. The other important fact is most of us actually do not know how to do this kind of an analysis of a good paper versus a bad paper. And therefore, even if it's a bad paper which says something is good, we may not have the expertise to actually determine it for ourselves. Therefore, you need somebody to do critical appraisal before a manuscript can get accepted. And that's where we bring in the concept of peer review. Peer review, who is a peer? Peer is somebody just like you. That's what a peer is. So a peer review is simply people who are similar to you, your colleagues, your peers, who are trying to assess the validity of the work that is being submitted. So you could be on either side of the table. You could be the author who submitted that paper, or you could next day become the peer who's judging a colleague's work. And therefore, the definition of peer review, unfortunately, is not extremely clear, and it varies with different types, which means you could have a single blind, double blind, pre-publication, post-publication, which means the reviewer may know the author's name, the author may know the reviewer's name. The peer review may happen before it is published. There are now models where peer review happens after it is published. So multiple models of how peer review is done. The bottom line is that the objective is that it should be unbiased assessment by colleagues to judge whether the science that is being presented is good or valid. and ultimately to improve the content, not just to pull down a paper, but to actually improve the content. That's the bottom line intent of peer review. And unfortunately, all of us have suffered peer review. We've all submitted papers to journals, got them rejected, and only after about 2 or 3 tries, it does get accepted somewhere else. Sometimes it even gets accepted at a better ranked journal than the journal which originally rejected us. And therefore, we assume that that journal did not know what it was doing. You rejected me, but I actually got published in a better journal. And that's something that happens every day to all of us. Anyone who's either an author or a reviewer or an editor knows I may accept a paper or I may reject a paper, but it gets accepted somewhere else. So it's a flawed science. There are numerous problems with what we are judging. It's ultimately 2 people who are sitting and judging a work or 3 people sitting and judging, and they may be wrong. So it is a flawed science, but unfortunately, we don't have anything better. It's all that we know at the moment about how to work about it. And the flaw in the science is so great that one of the editors of Lancet once said that if you exchanged my accept box with my reject box, I actually wouldn't know the difference. Now, an editor of Lancet can say that because the bottom basic characteristic of everything it gets is probably good. But at smaller journals, fortunately, we still can differentiate between what's really bad and what's really good. So what is critical appraisal? Critical appraisal or evaluation of manuscript or anything looks at a few basic criteria. Some of these points that I'm going to talk about now have already been spoken about by Dr. Prabhu in the previous talk. So I'm going to avoid duplicates and I'm going to try and keep my talk to skip over some of the things that Dr. Prabhu already talked about in the previous talk. So the first thing is validity. Validity means, does it actually measure what it is supposed to measure? And how well distributed are the results? On the other hand, something is called reliability. Can the results be reproduced? So if you look at the top 3 pictures of the board, again, something which Dr. Prabhu showed, all the bullet points are clustered at one point, which means every time a bullet is shot, it goes to the same place. So the gun is very reliable, or the shooter is very reliable. It always hits the point where it is supposed to hit. Very reliable. But it's not valid because it's not achieving what it is supposed to achieve. And what it is supposed to achieve is to hit the center. Therefore, it's not very valid. The one in the middle is a person who keeps hitting all around the place. So it's evenly distributed. So it's valid, but it's not reliable. I don't know, he may have hit left today, he may hit right tomorrow. He may hit the center today, he may hit the top tomorrow. And the third one is the guy who hits reliably and it's a valid result. Always the midline, that's a reliable and valid result. And the same thing happens in science. The other thing you need to assess is applicability. Now, if you're driving a Ferrari on an Indian road, how applicable is that result? So let's say if I buy a new machine which improves survival, or let's say there's a new drug which improves survival by 1 month, which may be statistically significant, but costs 10 lakh rupees per day. How valid or how applicable or how relevant would such a drug be to my scenario? And the other thing again about validity and reliability is your cartoon you see at the bottom. Can you really use a mouse to measure an elephant? How many mice will you need to measure an elephant? So something like that happens in our studies every day. You're measuring blood loss, but you don't know how to measure blood loss. You're simply measuring hemoglobin. Is hemoglobin a reliable measure of blood loss during surgery? Or let's say something like PCNL, when a lot amount of fluid is being blood is being lost in the fluid. Can you simply say that I'm going to measure hematocrit today and hematocrit after 2 hours? And is that a valid measurement for blood loss? So these are questions that you ask when you do critical appraisal. And again, we've discussed why it's required, because there is so much data out there that to be able to find data which is useful and valid, to sift out what is of value requires some degree of analysis. And where will you use critical analysis? You use it every day. We've talked about journal clubs. The principal objective of journal clubs is to do a critical analysis. You do it when you're reviewing a manuscript, but you also need it in your clinic if you're practicing. It's not just about academic medicine. You will have MRs walk into your clinic every day offering you new medication, new treatment. If just like the example I gave you of the car, if you're unable to judge the value of a new treatment, the value of a new device, you will not be able to make the right choices that you need to do in your life. So how do you judge critical appraisal of a manuscript? Now remember, the next few slides are common to writing a paper as they are to reading a paper. When you look at a paper, see that it answers 4 questions. Why was this study ever done? What was done? What was found? And why is it relevant? And that is also what we call the IMRAD format. So why was the study done? That is, the introduction part should give you that answer. The methods part should give you detailed answers on how they went about doing their study. The results should actually answer all the questions raised in the methods section. And then the discussion should put everything into context. Finally, as a reviewer, you must also try and make a judgment about the ethics of the study that's been done. So let's first look at the introduction. Try and understand whether this paper that you're reviewing answers 3 important questions. The first question is, what is the extent of the problem? So if you're looking at a paper on, let's say, radical prostatectomy, the paper should, let's say they're looking at nerve sparing, unilateral versus bilateral nerve sparing in erectile function after radical prostatectomy. So first it should tell you what is the importance. So they would have to tell you that radical prostatectomy results in ED. Now this is something all of us know, but it could be something more prosaic, which all of us may not know. So what is the importance of this study that they are doing? What is the part that is unknown? So we don't know whether unilateral is better than bilateral or bilateral is truly better than unilateral. So they should be able to identify a justification for why the study needs to be done. And finally, they should actually tell you what are you going to do about it. So we did a randomized trial, or we did a cohort study, or we did a retrospective study. So giving a vague introduction like we wanted to assess the impact of nerve sparing in radical prostatectomy. Now that's a useless introduction. What do you mean by impact? Does it make the person look nicer? Does it make the surgery quicker? Does it make the blood loss lower? Does it improve continence? Are you going to judge erectile function? I don't know. What do you mean by impact? Therefore, your introduction, when you're reading an introduction, you should be able to be really clear at the end of the introduction as to what is this paper going to tell you. If that is available, then that introduction has been a good one. Next, let's look at the methods, and this as a reviewer should be your principal focus. This is the place where the bulk of the manuscripts get judged for being good papers or bad papers. And here I would advise you to look at what are called reporting guidelines. Guidelines are available at a website of the Equator Network. It's not difficult to find. So if you Google Consort or Prisma, you'll find those guidelines. Those guidelines tell you what should you be expecting in a paper. So if you're reading a randomized trial, you're reviewing a randomized trial, look up the Consort guidelines. The Consort guidelines will give you, let's say, 15 or 20 questions. And as a reviewer, you should be asking those questions from the paper. And if you get answers to those questions, then that means the methodology has been well written. So the methodology should give you all these details about randomization and blinding. What were the endpoints? Was it blood loss? Was it hemoglobin? Was it continence? Was it erectile function? How was it measured? If it's erectile function, how did they measure it? Did they do a SHIM score? Did they do a full IIEF score? If it's continence, how did they measure continence? Were they weighing pads? Were they asking the patient? If it's urethroplasty, how do they say it's successful? What do you mean by successful urethroplasty? Did they measure uroflow? Did they measure patient's confidence? So what was measured and how was it measured? What was the outcome? What was the tool for measuring that outcome? All that should be defined in your methods section. And again, the concept of PICO, which both Abhishek and Dr. Prabhu talked about, must be covered in the methods. Then when you talk about the results, your primary objective is that if in the methods, they said we will, let's say, look at 10 points, your results should give you all the 10 answers. If they say we will look at complications on day 1 and day 30, your results must give complications on day 1 and day 30. The other important thing that you should see in the results is that they're not interpreting it. They should say we found a very low number of complications. Don't say low in the results. Just say what were the complications. The low comes in the discussion. So when you're judging the results part, try and understand, try and find out whether everything that needed to be given is given, nothing has been hidden, and that the data is as complete as possible. Then when you're looking at table and figures, now this is a place where a lot of people make mistakes because many of the papers that you read have been converted from thesis. So people give you the same data in the text, in the figure, and in the table. So age was, let's say the gender range, the sex ratio was 40 male to 60 female. This will be given in the text. You'll have a table which will say 40-60. You'll also have a pie chart of 40-60. That is nonsensical. That may work in a thesis, it doesn't work in a paper. In a paper, don't allow duplication of data. Some data would be duplicate. For example, the table may have a number of parameters and the most important one would be given in the text, but only the most important one. So avoid duplication of data between tables, figures, and text. Finally, you judge at whether the value of the results and whether the results make a difference, make a significance. How big was the difference? Was the difference just statistically significant but clinically irrelevant? Like I talked about the survival in a chemotherapy trial. Sure, the patient survived 2 months longer, and sure, that is statistically significant. They recruited 5,000 subjects, so even 2 months was statistically significant. But is it of real value? When the baseline survival is 36 months and you get 2 more months, how relevant is it to my patients? Will it help them? Can they afford it? Is it worth the harm? All this is judgment that comes into results. So the results are correct. You're not saying that the results are false. There is a benefit, survival benefit. It is statistically significant, but does it make a difference to me? These are points which must come out in the discussion section, which should not just say, I found 20%, X found 5%, Z found 20%. That is not a discussion. The discussion should explain to you why this result is relevant. So I found 20% complication rate. X found 10%, but then in my center, there are 10 of us who are operating. This 20% relates to 10 people. Some of us are just 2 years out of MCH, some of us are 30 years out of MCH, and therefore our 20 years experience is a mixed experience in real life compared to published literature, which is 10%, but all done by experts. Now that's a good discussion. It explains why your result is either the same or different from somebody else. That's a discussion I want to read. Not that mine was 20, X was 25, Y was 28, Z was 23, and therefore we are very good. That's a useless discussion. Now let's talk a little bit. Okay, finally, the section on conclusions. Remember, the conclusions should be really very short. The conclusion should be a summary of the most important result that the authors found. Should not be more than, let's say, 50 words or 65 words, 100 words, no more than that. Not even 100. 100 is also too many. And should be concise and to the point. They should not be extrapolating things. We found that bilateral nerve sparing had better continence. Therefore, we recommend it even though it takes longer operating time. Now, if they did not measure operating time, they should not say it takes longer operating time. Only if they measured it should they say it. Now let's come to the second section, which is going to be shorter and which is about how to write your report. The first part that I just discussed is common to whether you're writing a paper or reviewing a paper. The part that I'm going to discuss with you now is about when you're acting as a reviewer and you're actually writing the report for the journal. So what does the author expect? And think of what would you expect from a reviewer. You don't want him to say, bad manuscript, throw it out. That's a useless review. It doesn't help the author, it doesn't help the editor. The author wants to know, the nation wants to know, right? The author wants to know, what did you like about my paper? What did you not like about my paper? Why did you not like it? What do you think I should do to make my paper better? The basic expectation from you as a reviewer is, help me make my paper better. If there are things that you did not like about my paper, that's fine. Tell me what you did not like, but tell me why is it important to know this and what can I do to give you that answer. Your basic objective as a reviewer is to help make the paper better. For an editor, I of course want to know what you want to convey to the authors, but I also want you to give me a separate section on what is overall good and what is overall bad about the paper. So you might say that the paper has been done well, everything is fine, but I don't think it's going to work in it. So don't put that in the part that you write to the author. Put that in the part you write to the editor. So in the author section, how do you write it? A good way to write a review for the author section is to begin with a paragraph that summarizes what you have understood. So if you've understood that the authors report a study comparing unilateral with bilateral nerve sparing in radical prostatectomy and find that the continence rates with bilateral nerve sparing are similar to the continence rates with unilateral nerve sparing, and therefore they suggest that there is no point in doing bilateral nerve sparing. Simple summary. The importance of this summary is it makes the author and the editor confident that you've understood the paper. This is what the author wanted to say. You've understood what the author wanted to say, and therefore the value of your comments becomes more. Otherwise, as an author or as an editor, half the time you wonder that did the reviewer even understand what the author wanted to say? So when you summarize what you've understood in the first 3 to 4 sentences, you make yourself sound more intelligent. Then in the next few paragraphs, you should write about the importance of what this study is all about. Is it an important area of research? Is it a bad area of research? Is there a lot of work already done? And then what did you like and what more do you think you should have done? Write your major concerns first. The major concerns usually are about methodology. What are your major issues with the methodology or about the research hypothesis? That should come first. And this is where you might write that the consort guideline says you should tell me how many patients were screened, but this manuscript does not tell me how many patients were screened. And therefore, that is information that should be given. The authors do not tell us how allocation concealment was done. That's methodology. So that should come in the major point. Then come the minor points, which is more about tables, grammar. The grammar can actually be avoided. You don't really have to comment about grammar. But references, style of writing in tables, those are minor issues. When you write to the editor, you can be a little more clear about things you don't want to write to the author. You don't want to write anything opinionated about to the author, but to the editor, you can say that the paper has been done well, but I am not very sure it is relevant to my country or to this journal. I'm also concerned that they did not take consent properly, or I'm not sure that the subjects were adequately treated or trained. All those concerns should come in the section to the editor. Don't focus too much on language and grammar. None of us is an English native speaker. We have all learned English as we've grown. So if there are errors, it is the editor's job or the journal's job to clean up the language. Don't bother too much about language. And finally, you should also give a recommendation as well as your conflicts of interest. I am biased against this author. I am biased against this institution. I have a strong opinion in favor or against this particular surgery. Put that in the later section. So the do's and don'ts, finally, be always polite. Don't be aggressive. Don't be overcritical. Don't be harsh in your language. Your review should be constructive, trying to help the author make the manuscript better, even if you've said reject. The comments that you make should be that wherever they go to the next journal, they can use your comments to make the manuscript better. Maintain confidentiality. Don't go about bragging to him in the next meeting. Aapka paper aaya tha, maine padha hai. That's like a totally wrong way of reviewing a manuscript or saying, I've got a paper, I think it's yours. What do you want me to do about it? We've seen all this happen. Don't do stuff like that. You have to maintain confidentiality. Don't be late. If an editor has invited you to review and you accepted the invitation, do not be late. Submit the paper on time, because otherwise you're not getting a manuscript to review the next time. Do not be short or short-sighted, which means don't be very curt in your response and don't be short-sighted. Just because something is new or novel doesn't mean it's wrong. It may be something which is totally out of the box, and that's how new research gets done. Don't ask for unnecessary details. Tell me what was his father's engagement. All that is random stuff. You don't need it. Don't ask for it. So that's the final slide on writing a review. Remember what I said, if you can write well, you can review well. If you think you can review well, you can write well. They're interchangeable. But be supportive. That's your primary objective in being a reviewer. Your objective is to improve science, but your objective also is to voice an opinion if you think misconduct exists. Before you submit your review, review your review. What you've written the first time may be very harsh. When you're reviewing it, you may decide to tone it down a little bit and summarize what you've understood and why you think it's important. This is a resource you might like to use. The British Medical Journal ran a large series of articles on how to write a review. You'll find them all on the BMJ website. and you could use many of these articles for writing it. Thank you once again for the invitation to present, and I'm happy to be here once again. Thank you.
Yeah, thank you, Dr. Rajiv Kumar. And definitely, I think it will help all of us here and quite a few senior colleagues who have logged in, and we definitely will take tips from your presentation. And thanks again. Thank you for your presentation. Now, I'd like to invite Dr. Rishi Nair, who is also a professor at AIMS, and he is a part of the editorial for IJU. He himself has conducted an audit just recently and for the research, Collaborative Research Society of USI. And I think we can learn from him. And this is a very important topic for all of us to do, because it is relatively easy to do. And I hope Rishi can guide us still further in this topic. Thanks, Rishi. Welcome. Hello. Hello, Rishi, can you please
Hello,
start your presentation? Yeah, thanks.
yeah, are you able to hear me, ma'am?
Yes, yes.
Yeah, okay. So right now we have a power failure at my side, so I have logged in from my phone. Just give me a minute. I'm trying to upload the presentation on phone. So.
Yes, sir.
So. This is just now.
In the meanwhile, please put up your questions in the chat box if anybody would like to ask the speakers something specific which they could answer at the end of the session.
I think that would be better, because right now.
Ma'am, Dr. Rajiv is there. Dr. Rajiv is there. If we can have some questions from the audience to him, if Rishi is taking some time. Can I have one question to Dr. Rajiv?
Yes, sir. Yes, sir.
Dr. Rajiv, you covered in your presentation, again, a little bit more clarity for reviewer comments to the author and to the editor. How a reviewer should stick to the ideas, it should go separately to the editor and not to the author. You're muted, sir. You're muted. Yeah.
Sorry. So every journal gives you two boxes in terms of your reply. One box is for the comments to the author, and the other box is the comments to the editor. For the editor, the comments are usually much smaller and much shorter. The bulk of your comments are going to the author. For the editor, the most important decision, apart from what you've written to the author, is the relevance of the article and. So you may have given a very detailed response to the authors how to make the paper better. But at the end of the day, you feel that what's being discussed is not going to be relevant to the journal, or it's an area which has already been done many times in the past, that you write to the editor. That although the paper is done well, the study is done well, I'm not convinced that this is new or needs to be done, or I'm not convinced it will ever be relevant to India where the IJU is being published, for example. That is the part you write to the editor. You may also say that they've recruited 100 patients of lower pole stones randomized to PCNL versus RIRS in a period of 1 year. And I am not convinced that they are able to recruit so many patients in 1 year, and I have doubts whether the numbers are genuine. That should come to the editor. In the author's part, you would say what are the problems with the lower pole or the RIR study. So all that issue you would put in the author section. But in the editor section, you could raise a concern that I'm not sure so many subjects could have been recruited in this 1 year period. And therefore, you may want to look at the data or validate it. So these are the differences in what you would write to the authors and what you would write to the editor. And all journals give you two boxes. One is for what is to the authors, and one is what is to the editor.
adding further, if the result is unfavorable, do you think the researcher who has got the letter from the editor regarding the unfavorable result has the right to know the comment from the reviewer as well as the comment given to the editor?
No, no. The comments that are communicated to an author are decided by the editor. It is entirely the editor's discretion as to what comments are to be communicated to the author. The comments that are given by a reviewer to the editor are completely confidential. Sometimes the editors may pick and choose some of those comments because they believe they're relevant enough to be communicated, in which case it is fine, particularly in a double-blind peer review. But in an unblinded peer review, supposing the author and the reviewer are supposed to know each other, and the reviewer has given a comment completely in confidence to the editor cannot disclose that comment to the author. When the review is double blind, which is how it is for almost all our journals, the editor may choose to make certain comments, confidential comments, be available to the author without disclosing the identity of the reviewer, and always only those which can be substantiated. So the editor has this responsibility of checking what gets communicated to the author.
Thank you. Rishi, are you ready?
Yes. So
Rishi?
are you getting the slides, sir?
Not yet.
Okay.
Not yet. So I've already shared from the phone.
Rishi, if you have a problem, you can mail to central office or to Dr. Sujata. She will run from her end.
Okay.
I think best is you mail to Kiran. Yeah, in the meanwhile, Dr. Rajiv Kumar, I have one question for you. Like as when a reviewer, we write our comments to the editor and the author, usually it gets corrected and resent. But to the editor, like if certain comments, as you mentioned, like certain candid comments are written, then should we expect a reply from the editor?
Good question. It's very variable. Supposing you've raised a serious concern of misconduct, the editor may take a decision to reject the manuscript because they agree with your concern about misconduct, in which case you will always get communication that the manuscript has been rejected. And therefore, that will tell you that your comments have been taken into account. Sometimes the editor may directly communicate with the reviewer that you've raised a certain important issue. Can you clarify to me why you've raised it or why do you think it? Sometimes the editor will get back to the reviewer and thank them for that. We've done that from the IJU many times, that the reviewer has picked up some serious issue, communicated it to us, and then we've just sent a personal email to the reviewer that thank you very much for picking it up, and we've taken note of it. So it may not always happen, but yes, sometimes it does.
Dr. Rajiv, there's a question in the chat box. This is from Dr. Manav Suryavanshi. He's asking, we should have a session on data points that need to be caught for a study. How to make a great Excel sheet that brings out a good paper. You have any quick comments to that?
Well, Manav, that is actually the holy grail of doing research. If I could give you all the data points to capture in every study, that would make the perfect answer. Unfortunately, we don't. It obviously changes with every study. It depends upon what is the study, and therefore what data points need to be captured will depend upon what is the study that you're doing and what you're trying to assess. My very simple suggestion to everybody who's doing a study, our common problem is that we say सब कुछ इकट्ठा कर लो, बाद में देखेंगे क्या useful है. Let's collect all the information possible and then we'll see what is useful. That's a very dangerous way of doing a study because the bigger is your Excel sheet, the more will be the missing information and the more will be the gap. So when you start your study, at that point itself, try and limit the amount of data you need to capture and make your Excel sheet only to capture that many pieces of information. Then it would become worthwhile. And of course, the number of data points to be captured would change. I think Rishi's got his slides up, so I'm going to keep quiet now.
Okay, thank you, Dr.
Okay. So you are getting my audio and slides both?
Yes, yes, please proceed.
Okay. So thank you. Sorry for the technical glitch here because of the power failure. Anyhow,
No problem.
yeah. So I am going to talk about doing the clinical audit and how it should be done, why it should be done. You have seen the clinical research and clinical work studies, how they should be done in the previous 3 presentations. So the all objective of doing any such clinical work is to improve upon whatever our existing practices are. So the 3 important sub steps in that is we should first know what is the existing of that particular subject that we want to assess, and then we compare with the known or expected outcomes, and then subsequently we can plan some kind of a intervention or experiments to improve upon that outcomes, and this cycle goes on circularly to and ultimately with the goal of improving the overall outcomes for our patients. So when we apply these principles to our clinical research, we describe these studies as a descriptive study where we assess the existing whatever we are assessing about, and then we compare with our previous knowledge or with any other type of surgery or any other type of outcomes in form of observational studies, and then we intervene using either some drugs or surgery as an experimental study. So the same principles when they are applied to the clinical governance side, the clinical research establishes the standards, whereas on the clinical governance side, when we apply the same principle, what we call as the clinical application, the study is called as the survey when we are assessing the whatever the existing knowledge about that subject is, and then we assess in terms of audit by which is equivalent to doing an observational study where we assess the whatever the existing pattern is against the previously described baseline guidelines which should be followed. So we are comparing in an audit, but no comparison is being done in a survey. And then there are experimental clinical application studies similar to an experimental study on the clinical research side. Overall goal again remains the same for both the type of applications, and it is about improving the overall patient care and optimize the use of resources, which may be additional use of doing these kind of studies on the broader clinical application side. So just to give you a brief overview, the audit is not equivalent to a clinical research. A true clinical research is not same as the audit. In an audit, it is a survey where we are examining the actual practice established, actual practice against the established standards. Whereas in a research, we are creating new knowledge, we are creating new standards and adding to the existing pool of knowledge. So therefore, audit and research cannot be used as synonymously or interchangeably. In a research, we are evaluating a practice or comparing the alternative practice at a relatively micro level, whereas in an audit, we are examining the practices at a much broader and macro level. However, these methodology and the statistical methods we apply for doing the studies, the designs, the procedures we follow, how we analyze and how we interpret all the data, that all remains the same whether we are doing an audit or we are doing a research study. Audit is not equivalent to a survey, as I've already told you. In a survey, we are just examining the practice patterns where there are no standards are yet known. Whereas in an audit, we already from the clinical research, we already know what should be done or what gives better results, and then by examining the practice patterns, we are actually collaborating it against or measuring it against the established standards. The systematic approach, again, as I said, it remains the same. In healthcare delivery, as a country, we are lacking far behind the other studies. In UK, the clinical governance and the use of clinical audits in providing healthcare is in vogue since last 30 years or so. And as a country, we have not yet come up to this idea of using the clinical governance model. So clinical governance actually includes a clinical audit as the first step, and then from doing the audit, we assess the clinical effectiveness of any particular practices that are being followed at a macro level. and how that those practices are going to impact the outcomes, the side effects, etc. And based on that, new research is conducted, and further newer developments are being made in the field of healthcare delivery. This also simultaneously brings about openness and transparency in the delivery of healthcare, and the use of technology and surgeries or medications, whatever we are using, and also helps in risk management. So all this taken together is combined in the term clinical governance, and clinical audit is just the first step of giving a improved healthcare delivery. So 2 years back, the Collaborative Research Committee was started under the umbrella of Urological Society of India, and since clinical audits are one of the first steps in giving in the delivery of healthcare system and developing guidelines, so we started the doing audits as the first kind of study that would be done under the umbrella of Collaborative Research Committee, and Dr. Sujata Patwardhan was the one who took up the first study in identifying the practice patterns related to the BPH treatment in our country. And then the second audit was started by me and all other colleagues who were part of the collaborative research group for the antibiotic use before the endourological surgeries in India, and we will come to that as we go along, how we did that and what were the findings of that. So by using the clinical governance on a larger scale for healthcare deliveries, so this is relevant not only at a national level, this may be relevant even at a level of simple nursing home. The same way that you do your financial audits to find out how your where your money is coming from, where your money is getting expenditure, what are your profits and what are your losses, how you can reduce the losses and give more profitable healthcare delivery in a smaller expenses. So similar kind of way, similar ways can be applied to a clinical approach, clinical treatment pathways also, with the goal of improving the patient outcomes. The objectives are basically to reduce the burdens on the society, or to the, if it is being used for a nursing home level, they reduce the financial burdens on the both the patients and the nursing home. It can also come down further to a lower down level of a specific disease or its management, like the side effects of drugs or surgeries, or the emergence of super pathogens. So any particular topic can be used, but the overall goal would be to improve the patient outcomes. And as I said, once you go into it, once you start auditing all those things, you create new questions regarding the practices, and ultimately you may end up finding solutions to which may have a wide impact on the overall clinical governance. And bringing out guidelines and public health recommendations is only one part of it. So there are huge benefits to be gained by doing the clinical audits and overall clinical governance model. The clinical audit per se, other than the governance model, you see, when you are doing a clinical audit, you are creating an awareness on the subject. All those who are participating in it, whether it is nursing staff or para nursing staff or the treating physicians themselves, they have to read about it, but and then therefore there is a awareness being created subconsciously, or as you start the auditing process, and simultaneously one would be able to identify and measure the areas of risk. And once we are auditing all those data, we have to keep up to date with the evidence base. What is the what are the evidence available, what are the good practices, and what is actually benefiting the patients. So therefore there is a inherent need to keep up to date with the existing knowledge, and there are benefits to be gained in terms of the conduct also. When we are doing these things, we have to follow the professional standards, and therefore there is a simultaneously professional development also going on. As a faculty, we tend to know deeper into the subject and what all is affecting it, and this therefore also helps in simultaneously for the paper writing and the review also, as you heard in the previous lectures. And it creates a culture of transparency, collaboration, and quality improvement. So all those stakeholders who may get affected by it, they come together and collaborate, and ultimately there is a quality improvement with the overall goal of improving the uh, the uh, healthcare delivery. So doing a clinical audit is not a one-step process, as you can assume that once the audit process is set in process, uh, uh, it doesn't end up at the data analysis and giving recommendation. One has to also think of implementing those recommendations on the same stakeholders which have provided the data or the larger population over which it is applicable. So after implementation, you give some time to improve upon the processes, and say after 6 months or 1 year or 2 years, one can repeat the audit and see what are the impacts of those renewed guidelines or renewed practices that have come into force, and whether we have moved any further, improved upon our practices in that sense. So therefore, it is a continuous quality improvement process and not a one-step uh, process, which, and indeed any scientific knowledge has the same cycle to follow. So as I said, we should know whenever these cycles are being done, whether we have achieved the set forth goals or not. And for that, again, the same kind of methodologies are going to be followed subsequent to doing the audit also. It's not that the methodologies would remain limited to the audit. So coming to the how to exactly plan an audit, the protocol is the first step. As for any other study, we have to write the protocol in as much detail as possible. The question for the audit has to be decided in the same way as we decided for doing, whether we are doing a thesis or whether we are doing a clinical study. The title to be chosen and should have a clear potential for improvement of the practice, policy, or service, and it should be a area which should be aligned with the institutions or the nation's priorities if it is being done at a macro level. And for an audit, you should see that there should be some standards or guidelines that are already there and exist as at least as a good practice guidelines, if not evidence-based guidelines. Then you design your audit, and for that you need to know what are the infrastructure available, what manpower would be required, what are the resources at hand, and how much monetary backing would be required, the funding that is necessary, and ultimately what are you going to measure for that audit, whether you are specifically looking at patient related outcomes, pain relief, satisfaction, or you are looking at the side effects of drugs, etc. The framing of question would follow the same principle. As I said, the statistical methods, they do remain the same, whatever type of study is being done. So the PICO principle, SMART principle has to be followed for designing the question. And all these are related to your framing the question. So the question should be as detailed as possible, following all these principles, and then based on that, the methodology itself has to be defined, predefined in the protocol before the audit actually sets in motion. Then the question comes, where are you going to enter your data? How is your database is going to be decided? So that database should have integrity, should be able to provide all that you require in its completeness, and the security of the project data, the privacy of the patient's data should be prevented at all times. It should not be available to everybody. The patient's data should remain anonymous, as is the surgeon's data or the institution's data. That should not come out in any publication and should not be available to any unauthorized personnel. So the database may simply be an Excel chart for a small level audit process, but for a large data set, sometimes it may become difficult to enter data manually by oneself in an Excel sheet. And there are applications available which are logic-based applications and freely available online, like RedCap. If one is well versed with it, they are easy to use and available freely. Nowadays, USI has also developed a repository to enter the data for its collaborative research projects that are being done under its umbrella. So therefore, USI may also help if somebody is willing to do a large-scale clinical audit or any other kind of study for that matter in this regard under the umbrella of USI. So even audits come under the purview of ethical approval. We cannot conduct audits just like that without a proper ethical approval. And in our country, we are guided by the CDSO guidelines, the ICMR guidelines for doing any new studies, and good clinical practices as defined under the World Health Organization. So if somebody is interested, they are available freely online on the government websites. So all those guidelines are available, and even audits have to be approved at each individual participating center through the ethical committee. So after this comes the how to do a clinical audit. That is actually becomes easier if the protocol has been designed well. What is important is good planning. So minimize the workload on the people who are going to enter the data. So if you make your performa too lengthy, say 200 questions, 400 questions, the data that is coming, that would come ultimately would be good. But the amount of data that you will get is going to be very less, and ultimately what you may not be able to derive logical conclusions out of it. So therefore, keep your performa as short as possible and as relevant as possible and as valid as possible to ultimately be able to decide what you are specifically looking at. That outcome based designing should be done for the protocol. So you should be having a dedicated staff, and finally the analysis of the results can be done. So finally comes the analyzing the study. It is probably the easiest part of the study. Once the data is collected, you can analyze it using any statistical softwares which are available, or you can use even the Excel chart. And finally comes the implementation. As I said earlier also, audit doesn't end with the end of the study and finding the results of that audit. One has to then compare it with the existing data sets and knowledge, and then try to give some recommendations based on that, so that how we can improve upon the current practices which are prevalent. And then subsequently a new audit would be done as at a later stage on either on a similar lines or with an improved methodology based upon any new evidence that may have come through the clinical studies. So then we can re-audit based upon the benchmarking or redesigning the studies, and the patient and public involvement can also be made, and ultimately a consensus may be achieved based upon the new evidence that the audit has created, and finally we can repeat the cycle. So this was the second study that was done through USI, where we assessed the use of the antibiotics in the immediate pre-op and perioperative period for doing the endourological surgery. So we defined our project in a very methodological way. The project was developed and the timelines were also predefined before we actually set the project in motion. And we got all our ethical reviews, and the sites were recruited through the help of USI, and the advertisements were sent through the USI office. The case accrual and follow-up was done over 4 months, and all the centers were entering the data prospectively on a database which was designed by us, but then developed through a technological team which was provided through the Urological Society of India. And so ultimately we were able to find some findings. As you can see, the north and south zones of under the USI contributed most of the cases. And what we found actually was that as a nation, we are still using a higher antibiotic as a preoperative prophylaxis. More than 50% of the cases are using beta-lactamase inhibitors like piperacillin tazobactam, cefoperazone sulbactam. Whereas if you see the guidelines, what is recommended is to use antibiotic which covers about 70 to 80% of the local antibiotic flora as a prophylaxis. The lowest spectrum antibiotic that covers 70 to 80% of the flora should be used, rather than trying to use the antibiotic which will provide a cover to 90 to 100% of the flora. So that way we can reduce the development of the resistance to the antibiotics. Another important finding is that we continue to use our primary prophylaxis for more than 1 day, even after the procedure in more than 53% of the cases. Again, this is discordant with the existing literature, which is a high quality evidence already available through randomized controlled trials, which clearly show that a single dose antibiotic or at the most 1 day prophylaxis is sufficient for more than 90 to 95% of the patients. Again, the practices are different from the existing guidelines in terms of the use of the second antibiotics, which means that 2 or more than 2 antibiotics are used simultaneously as prophylaxis. Amikacin is the one which is generally combined with the premise of improving the spectra that is to be covered for covering the endogeological flora. But as I said, there is clear evidence to suggest that only one antibiotic is sufficient, and generally the third generation or the second generation cephalosporins, they are sufficient to cover most of the organisms in as a prophylaxis. And then finally, we found that regarding the urine culture, preoperative urine culture is not being done in more than 1/3 of the cases. Either it is there is a significant growth, insignificant, or it is not done at all. So in more than 1/3 of the cases, the urine culture is not available preoperatively, or it is actually positive. So again, this is a guideline discordant, which clearly state that urine culture should at least be done, and if positive, it should be treated. And post-op prophylaxis is also actually being heavily used in our country. We continue to write antibiotics more than 3 days of duration in 88% of the cases, which is again guideline discordant. Guidelines do not recommend use of antibiotics at discharge at all. When we talk about doing a clinical audits, we are actually the stakeholders. It is only our involvement and commitment as a stakeholder, which is the prime factor, both in doing the study as well as in implementing the findings, what we find. And ultimately, we are the ones who are going to improve our clinical practice and improve the results of our practices for our patients. So the necessity of clinical audits is evident to all, but it is only our adaptation and acceptance to doing those audits which is lacking at the moment. So this is my final slide, and I would say that audit is just the first small starting step to bring about a big change, and we should imbibe the practice of doing audit in our clinical use as far as we can use. Thank you very much, sir.
Thank you, Rishi. Thank you very much. And I more than agree with you, because when I was reading about the BEP audit, I found that every year UK does its BEP audit, and we have not ever done it, and in all these years. So I think there are many more topics where we can think and do
Yes.
more better work. Thank you for your nice presentation. And Dr. Rajiv Kumar has kindly addressed most of the questions in the chat box. And so If there are no more questions, then maybe we can come to
Can
the.
can I have one question?
Yes, sir, please.
This question is to Dr. Rajiv and Dr. Vinder Prabhu. Is Dr. Vinder Prabhu there online?
Yeah, he's there, sir.
Yeah.
Yes, sir. I'm
Dr.
there, sir.
Rajiv and Dr. Vinder Prabhu, let us assume we want to just promote the science of how to do the art and science of how to do a systemic review and meta-analysis. What is your message to the residents or the young researcher? How they should build a team and how much roughly time taken for doing a good SRMA? This is a question to Rajiv and Dr. Vendababu both.
Let me
sir.
begin by, sorry, go ahead, Dr. Prabhu, you want to answer first.
No, sir. Please go ahead, sir. Please go ahead, sir.
Okay, so for my advice to most residents at the moment would actually be to do a study of their own first. Systematic reviews and meta-analysis are fine for people with a little more experience in what is being said and what is being done. There are two parts of a systematic review and a meta-analysis. One, of course, is the conduct of the actual literature search and doing the meta-analysis, if you're doing meta-analysis, or just writing up the systematic review. But whenever you review, either as a systematic review or a meta-analysis, you have to ideally have some background knowledge of your own as well to be able to do a justifiable analysis and reporting. And at a level of a resident, that is often limited. And therefore, while they must understand reviews and meta-analysis, and I've seen some very good reviews come from residents as well, they've been published, we've published them as well. I would request them to consider focusing on understanding research and research methodology first. And once you grasp that you move on to doing a systematic review and meta-analysis. Don't build yourself up to do that as the very first paper that you write. That may not be the right approach. Dr. Prabhu?
Sir, I think you are very right, sir, that it is not for a person who's starting off the research. Of course, for management of patients, definitely, and to understand the process, we need to read the systematic reviews. Well done systematic reviews have to be read, and that would give us an insight into how this could be done. And again, if I could talk from the viewpoint of the Cochrane, they would never allow a fresher to start on his own. They always have on board a person who has already done a Cochrane review, should be one of the authors of the review. And again, if the team should be diverse. So if you have a diverse team, which could include an information specialist, it has preferably a statistician on board and a subject expert, and 2 or 3 people who could independently review the studies. If such a team is available, and this could be possible only in probably possible only in academic institutions, it can be done. And on the other hand, also, since nowadays the reviews need not be the person, authors should be physically present at one place. They could correspond across the country or internationally. And so if you have interested people, it could still be possible. But again, as you told, it's not possible, may not be that much easy for residents starting off. Probably they should do few studies like observational studies on their own, read a few systematic reviews which are well done, and then venture into it if they want.
Yeah, thank you, Dr. Rajiv, and thank you, Dr. Prabhu. This was one of the observations we have seen. Few people who are not good in scientific writing, but they are very good in reviewing. I don't know. This is that's why I just shared my thought, and probably you answered it. How to make a team, how diverse should be a team, and how resident, especially resident, should focus on just doing a first study on his own, learning a correct methodology, and probably once he involves with time, he can be a part of a team of systemic review and meta-analysis. Yeah, point taken. And Dr. Sujata, do you have any more questions on the chat box?
Next, sir, there are no questions on the chat box.
Before I hand over to you for the vote of thanks, just for the sake of information to the members, both residents and the full members of USI, this was one of the first collaborative program with ISU, which Dr. Rajiv was shared with them. Immediately agreed. And we have a couple of more, probably that will be virtual, and we are planning on physical. This is based on the questions and the doubts which are written to us by the resident as well as the other members. And Dr. Jeev is helping us in this level. Again, one of the comments from the Dr. Santosh was there that we need to have a little more system in place where the presentations go, whatever is present in the form, mode of application. So we have some program like this in pipeline where we are having a meeting of young academic neurologists training the DNB as well as the MCs residents, just focusing on those, and with the help of IGU, we will be fine-tuning their skills in research and writing. Over to you, Dr. Sujata.
Yes, sir. I would like to thank our president and secretary for joining in for some time, in spite of they being busy. And thank you, Dr. Rajiv Kumar. It's always inspirational to listen to you, and Rishi for your nice presentation on audit, Dr. Prabhu and Abhishek for your guidance. And I would like to thank the USI team, Kiran and Navneet and Dr. Chawla for thinking of this nice program, and all the participants. It was really kind of you to come in such big numbers. Thank you very much, and we would like to end this program.
Thank you. Goodbye.
Thank you, sir.